Good afternoon. This section is on respiratory and simple ventilators. It's module 4 of the C3IFT course to get you certified to that level. We're going to take a quick review of the anatomy system, talk about things that relate to pulmonary blood flow, how we're going to assess and manage our patients, and be familiar with our vent and how to manage those patients that need paralytics, as well as our tracheostomies and how to troubleshoot the vent. So our respiratory system is responsible for the big question is, what is the ventilation versus respiration? Well, ventilation is the mechanical process of bringing air into and out of the lungs. So we're bringing oxygen into the body and into the bloodstream. Whereas respiration is the actual gas exchange. So we're talking about chemical gas exchange. So we're bringing oxygen into the cells. It is being converted for the use in metabolism, and we are excreting the waste products such as carbon dioxide. When we talk about the anatomy of the airway, we do know that it's divided into an upper and a lower airway, and that cutoff point between upper and lower is at the larynx. So you're talking about everything from the nares, the nasal passages, all the way back into the nasopharynx, the mouth, the oropharynx, and then also includes a structure such as the tongue and the epiglottis, and it extends down to the larynx. And from that point, we're talking about the lower airway, and we're talking about the trachea. So the trachea branches down into the right and left main stem bronchi. Then you end up with the primary, secondary, and tertiary bronchioles, so they keep getting smaller and smaller branches until they finally end in those, the alveoli, or the little bundle of grapes, and that's the site of gas exchange. So the big thing also physically to remember with the airway is that your right side of the main stem is wider, it's shorter, whereas the left angles off more, and that is to compensate for space to allow the heart to sit in the chest cavity. We know that the purpose of the upper airway is to conduct air down into the lungs, so it's part of that pathway. The purpose is to warm, humidify, and filter the air that's coming through and make sure that it's ready to be received by the lower lungs. With the lower airways, the bronchioles, these are very small, and you have the elastic bands that wrap around it, and that helps with bronchoconstriction and bronchodilation. And then, of course, you have the termination of that, which is the alveoli, and they are 1 cell in thickness, and that allows for good, adequate oxygen exchange in a normal physiology body. Of course, pathophysiology will change that. Now the lung parenchyma, this is the functional unit of the respiratory system. This is when we are specifically looking at the bronchioles and the alveolar sacs. There are 3 types of cells that make up the alveoli. You have one that are called pneumocytes, and of course these are the ones that are involved in gas exchange, whereas the type 2 cells, those are the ones that produce surfactant. And the surfactant is really important to keep the alveoli, the inside of the alveoli, lubricated so that they don't collapse. If they collapse and collapse in on themselves, then they stick together. It's kind of like if you ever pulled saran wrap off the roll and it wrinkles up together and you have a hard time getting it apart, and it seems like you get one side straight and then all of a sudden the other side sticks together. That's what the surfactant prevents from happening. So if you wanted to do the experiment to get that mental idea in your mind, then you're looking at spraying PAM, the PAM oil spray actually on the saran wrap, and then when you pull it off, you know, it's not going to be able to stick together because that PAM spray, that oil acts as the surfactant to keep those sides from sticking together. And then the third type is the alveolar macrophages, and these are the ones that are responsible for engulfing and cleaning up any foreign debris and matter that comes into our lungs. We do have some protective mechanisms to help maintain our airway, and that includes the mucociliary blanket. And what they're really saying here is you have the mucus, or the little goblet cells, that are responsible for squishing the mucus out, and the mucus is going to grab any materials And the cilia are the little fingers, those little finger-like projections that help sweep and move the debris up out of our lungs. Is what initiates us to cough. But during intubation, when you talk about the cilia in the upper airway passages during intubation, that component is being bypassed. So that deals in dry air, so it's not getting warmed and humidified and filtered. So you're looking at some complications there if we don't have them on humidified oxygen. But some other protective measures include coughing, sneezing, and we also talk about a yawn, and the yawn actually helps the alveoli to pop open and helps to increase the production of the surfactant. So we also look at not only the lungs, but you have the center cavity that divides the right and left pleura, and that center cavity is called the mediastinum. We can't forget those accessory muscles. We have those intercostal muscles that help in the muscle contractions that allow the lungs to expand and contract, and we must include the diaphragm in as part of the anatomy that involves the airway. So with the pleura, you have the visceral and the parietal pleura. The viscera is the one that covers the lungs. It comes in contact with the lungs, or the lung tissue itself, and then you have the parietal pleura that actually touches the cavity, the space in which the organ sits. So you have the visceral and parietal pleura, and in between those you have that thin film, and that film in that pleural space is what allows the lungs to kind of move around. It lubricates the lungs and allows that expansion and relaxation to occur. If you've ever had pleurisy, then you've had an infection in that pleural space where that pleural fluid sits, and that infection doesn't allow for that nice pretty movement, and it's like rubbing two pieces of leather together, and it kind of grabs and causes all kinds of issues. It's very painful. So with the blood supply, remember your ventilation is the mechanical process, respiration is the actual gas exchange. So we talk about pulmonary gas exchange. This arises from the right side of the heart to the lungs and then returns that oxygenated blood to the left side of the heart. And you have bronchial, which arises from the systemic circulation. And your pulmonary circulation is taking that deoxygenated blood from the right ventricle, it's picking up the oxygen in the lungs, and it's taking it to the left atrium, and that allows blood to be oxygenated for systemic circulation. So we talk about pulmonary blood flow. You are leaving the heart by the pulmonary arteries. It is passing into the lungs, and you have those arterioles that, and then you turn into the capillary beds, and that's where the gas exchange takes place, and then it will return via the venules and the veins and through the pulmonary veins back into the heart. So ventilation, actual mechanical process of moving air into and out of the lungs with maximum efficiency in the exchange of gases between the blood and the alveoli results when ventilation and perfusion correspond equally. So sometimes you'll hear about them talk about a ventilation to perfusion mismatch. So that's when you're ventilating like you're supposed to, but the perfusion is not taking place like it should. So when you're doing your assessment, when you first walk up to that patient, you're looking at them. So you have that inspection. What do you see? How is the patient breathing? Do you see signs of respiratory distress? Are you afraid that they may have some respiratory depression, or is there a potential for moving into respiratory arrest? And how are you going to handle that? So when you auscultate, you're actually listening, and what are you listening for? Well, you hope to hear those nice, clear lung sounds. You don't want to hear anything abnormal, whether it be fluid, junk, wheezing. You don't want to hear those abnormal things. And make sure you document everything thoroughly, what you hear and what you don't hear. So the adventitious lung sounds, these are abnormal lung sounds that are heard in addition to or maybe in place of the normal lung sounds, and we talked about that. So you hear the wheezing, so you have the bronchoconstriction that's causing the air to whistle as it's moving around whatever that constriction is in the bronchioles. Then you have rhonchi, and that's that thick, nasty, mucus, horrible bleh. And then you have rales, and rales is the fine pops and crackles that you hear. And then, of course, aspiration, you have an entry of material that's going into the airway below the true vocal cords. And when you have a patient who has suffered aspiration, it increases the chance of mortality significantly. So you always want to evaluate this patient. Do we always know if a person's aspirated? No, not necessarily. But we want to maintain a high index of suspicion in those situations where they're not able to maintain their airway. So pleural effusions is an abnormal layer of fluid between the layers of the membrane that lines both the lungs and the chest cavity. The most common cause is congestive heart failure, but you can also have inflammation of the pleura as a result of lung cancer, pneumonia, tuberculosis, and lung infections. And your symptoms include shortness of breath, maybe they're complaining of chest pain, particularly pleuritic chest pains. We're talking about when they inhale, they have that deep inhalation, can cause issues. Maybe they are presenting to you with coughs, that thick, nasty cough, or rapid breathing, or maybe they're just non-symptomatic altogether. But your treatment, if you have pleural effusions that are caused by CHF, those are treated best with diuretics such as Lasix and other medications that actually treat the heart failure itself to improve the contractility of the heart. Your pleural effusions that are caused by infection, they look more specifically toward antibiotics depending upon what the causative organism is. And if the patient has cancer or some sort of infection, then their goal is to probably do the chest tube in order to drain the fluid and try to pull some of that infection out. In any event, your patient can present to you in a myriad of ways. It could be that they're restless, they have anxiety, or they may become combative. But anytime you see those, you immediately want to consider that patient to be hypoxic until proven otherwise. Because you have to have the three things for your brain to function properly. You have to have oxygen, you have to have good proper blood flow, and in that blood flow you have to have sugar, and then the conversion agent to get the sugar into the brain tissue, and that's your thymine. So you have to have thymine, sugar, and oxygen getting to the brain for the brain to function properly. If it doesn't get one of those three things, then you're going to see alterations in the mental status. So other things that can come up, you can see drowsiness and lethargia. In that case, there could be hypercarbia. Again, you're still dealing with the hypoxia, and the hypoxia has continued to exacerbate to the point that the carbon dioxide levels are well outweighing it. So you're having that shift in your pH balance, and they're going to become very altered and very tired. When the fighting stops, doesn't mean the patient's necessarily getting better. So if the patient is on a ventilator, what are some things that you want to assess for, things you want to consider with the vent settings? Look at the pressure readings on the vent. It's very important to look and evaluate where the depth marker is on your intubation tube and the size of the ET tube. And whatever you find, you want to document it very thoroughly. So let's talk a little bit about ventilator management. The goal of a ventilator is to maintain the alveolar gas exchange that's appropriate for the patient's metabolic needs, and the goal is to try to correct or maintain to prevent hypoxia and or hypercapnia, or the increase in the carbon dioxide levels. So with mechanical ventilation, air is being pushed in to the lungs under positive pressure, and that's really important to understand that, because in normal lung physiology, it's all based on negative pressure. The muscles contract, the diaphragm contracts down, the chest wall contracts and pulls the ribs up, and that increases the space, but it's all about negative pressure pulling it in. Well, suddenly went from drawing it in through negative pressure to being forced down into their lungs. so to a degree far greater than the patient could deliver on his or her own. Positive pressure physiologically distinct from spontaneous breathing. Again, that's all about that negative pressure. So we are doing significant and not damage, but we're doing significant changes to the physiology in the lungs when we're forcing the air in by that mechanical ventilator. Most simple ventilators have 3 variable settings. You can set the tidal volume for your patient, the rate, and then the fraction of inspired oxygen. But it's very important to be very comfortable with your ventilators, or have someone with you who can make you comfortable with the ventilators, because if you're not proficient with those skills, you can kill a patient and cause them great harm and suffering. So it's very important to understand that ventilator and know what you're doing with it. So some of the settings we talked about, one was tidal volume, and tidal volume is how much volume is delivered with each breath. And the volume is going to be based on the patient's ideal body weight. And it's really important to remember that just because a patient may be 300 pounds doesn't mean that they have bigger lungs. Just because they're overweight doesn't mean that their lungs have gotten larger too. Their lungs are still based for their normal ideal body weight. So when we calculate tidal volume, we're wanting to calculate it at a rate of 7 to 10 cc's per kilo of their ideal body weight. So if we know that a patient is 100 kilos, then we want to calculate it based on that with a rate of 7, so you're going to look at 700 to 1,000 milliliters. The other setting that the ventilator allows you to adjust is the rate. And that's, again, your number of breaths per minute. The normal adult rate is 12 to 14 breaths per minute, but it can be higher or lower. But your rate has to be matched with the tidal volume to ensure that you're providing that patient with the correct volume over 1 minute at a time, or what they refer to as minute volume. So in order to calculate minute volume, you're looking at tidal volume times the respiratory rate to equal minute volume. Now what I'm going to do for you is I'm also going to provide in the course sites under content for this particular module, you will also see a formula to kind of help you calculate the tidal volume and get that minute volume more accurately than even what this presentation provides. It's not necessary, it's not mandatory, but it's good for patient care, and it's much more accurate in determining the right amount for your patients on the vent. So I am going to provide you with that, that calculation, and if you have any issues or you have any questions about it, you can just come by and see me. Then the final thing that they have is the fraction of inspired O2. So this is the concentration of oxygen that's coming in with each breath. We know that to be sitting here, me, talking constantly to you right now, I'm bringing in the 21% of oxygen that's in the atmospheric pressures around me. But when you're dealing with a patient in the back of the ambulance, we have a little bit of flexibility with that. We could give them up to 100% of oxygen. Now that's not necessarily a good thing, because what they have found is that when you have saturation levels greater than 94%, then you actually move into oxygen toxicity. So when we're dealing with these patients that are on a ventilator and we're trying to set that fraction of inspired O2, we're trying to maintain an oxygen saturation of at least 94%. But we don't want them, if we've got it at 94%, then that's fine, leave it there. We don't have to keep increasing it to get to 99%, for example. But once the blood gases have been obtained, it's possible to titrate the FiO2 based on what those findings are. And it's all about maintaining the pH balance appropriately in the bloodstream. But it's really important to understand that if you have a fraction of inspired O2 that's 50% or greater for longer than 24 hours, there's a high risk of oxygen toxicity at that point. One additional area that's important to talk about is PEEP, and PEEP stands for positive end expiratory pressures, and this is the amount of pressure that's maintained in the lungs at the end of expiration. So that's what prevents the lungs from collapsing, those little airways from collapsing entirely. So it increases the lung area for gas exchanging and improve the secretion drainage from closed alveoli. Typically, your settings for PEEP is 5 to 10, but in some patients who have severe pathophysiology, so we're looking at the COPD patients, the emphysema patients, for example, those PEEP settings in those cases sometimes can even be higher and up to 20. But the thing that you have to remember is that you're putting constant pressure on those alveoli, and if you get too high, you can actually cause barotrauma. You can actually cause the alveoli to pop and cause a pneumothorax. And then we do like to make sure that these patients have end-tidal CO2 measurement because it's so important and so necessary to ensure that the patient is receiving the right amounts of oxygen and that their body is able to compensate and tolerate and create the gas exchange, because it's all about respiration. And end-tidal CO2 tells us if respiration is taking place very well. So the normal end-tidal CO2 is 35 to 45, and two common things that can change the carbon dioxide is either the respiratory rate or tidal volume. So those are things that we have the flexibility to adjust based on what the physician tells us to do. So another feature of the ventilator is that you have a high pressure and a low pressure alarm, and the high pressure alarm typically will trigger when you have peak inspiratory pressure, so you have an increase in the pressures that are being placed against the vent. So that can be the result of a kink in the tubing, or maybe the patient is experiencing a bronchospasm, or they are experiencing cough. And the one thing we hope doesn't happen is that they're experiencing a pneumothorax. But the pneumothorax would trigger that peak inspiratory pressure and create a high alarm alert. Now, if your patient is an ARDS patient, this is adult respiratory distress syndrome, if they're suffering from ARDS, there's a good chance that you're going to have to adjust those high pressure alarms, or those peak inspiratory pressure alerts, because those individuals, their lungs are collapsed and it's taking higher pressures to keep that lung tissue open. And they don't understand a lot about what happens in the pathophysiology of ARDS. They just understand that it creates a situation where you lose the surfactant and you have this atelectasis where the alveoli are sticking together. And then the other case too is maybe your patient is coming out of sedation and they're starting to fight the vent. Maybe they're trying to react or respond to what the vent is doing to them. And in the low pressure alarms, typically when we look at a low pressure alarm, it's the result of a disconnect or something that's leaking. Somewhere in the ET tube, maybe the balloon cuff is leaking in the ET tube, or there's a disconnect somewhere in the circuit or in the tubing. But the big thing to remember is if you were ever unsure about a patient that's being ventilated and whether they're being ventilated properly, and you're having issues, you may just need to disconnect the ventilator and manually ventilate your patient while you troubleshoot what's going on. And the mnemonic is the DOPE mnemonic, and we're going to look at that on the next slide. So the DOPE mnemonic stands for displacement, obstruction, pneumothorax, and then finally equipment failure. So it may be that there's a displacement of the tube. You want to check your tube placement. Is it at the same depth that it was previously? Did it get dislodged? Is there an obstruction? It can be something as simple as a mucus plug that could be causing an obstruction. And then we also want to consider, is this patient suffering from a pneumothorax, or are we dealing with equipment failure? And if it comes down to it, we always have the ability to take them off the vent and use our nice little hand and do the bag valve mask and just do it, do it ourselves. Some of the big keys to remember when dealing with a ventilator is that you only want to adjust one setting at a time. If you've calculated the tidal volume correctly, then look at the rate. If the rate changes seem inappropriate, change the tidal volume. So you want to give the patient time to respond to whatever you do to them. So if you change that tidal volume, then you need to give time, watch the vents, see if that patient's presentation starts to change, and is it a good change or a bad change. But always notify medical command if you have to make a change on the ventilator. Some things to remember: frequent monitoring for breath, for bilateral and equal breath sounds throughout the transport need to be done. You want to always assess breath sounds after transfer the patient from any point. So if we take them from the bed to the cot, then we need to check and make sure that we have not lost that lung or that something has been displaced or dislodged. And monitor your pulse oximetry and especially your end-tidal CO2. And remember to have a plan, a backup plan available if your ventilator fails. Have that bag valve mask readily accessible so that you can initiate ventilations without that patient being hypoxic for any length of time. You also want to ensure that before you leave with that patient on your ambulance that you have enough oxygen necessary for the transport, and a lot of that is going to be based on the fraction of inspired O2 that is given to that patient. And remember that you need to make sure that this patient is medicated properly. We want to provide them the medications they need to reduce their anxiety or help them forget, provide them the medications they need for their pain, and the combativeness. And remember, we've taken something that is a negative pressure drawing in of air and we've made it into a positive pressure and we're forcing that air in. So it's very uncomfortable and it's not going to be roses. It's not going to come up roses. So it is going to be painful for that patient is my point. So you want to make sure that you have the proper medications on board. And this is a good time if you have not looked at your paralytic drugs, if you've not looked at the medications since the previous module, you may want to pull those up and just do a refresher on those at this point. Now moving forward, we're talking about tracheostomies. And your tracheostomies is an operative procedure that creates a surgical airway in the trachea. And the larynx is comprised of three large cartilages. You have the epiglottis, the thyroid, and then the cricoid cartilage. Tracheostomies vary based, there's a variety of tracheostomy tubes out there that can be either made from plastic or silver. They can be cuffed or uncuffed, fenestrated, unfenestrated. They can be single or double cannulated, open or percutaneous. There's a lot of different things that can occur with those. The big thing is to make sure that you have the obturator, and the obturator is what we would refer to as the stylet when we use for intubation, the stylus. The obturator is what's used inside the tracheostomy tube when it's placed. So make sure you have the obturator with you and make sure to hand over the device when you relinquish care to the primary care provider. And the best thing that I always said was to tape that obturator onto their chest, because then it'll always be with the patient and we won't accidentally walk off with it. But avoid overinflating the tracheostomy tube, because that overinflation actually places pressure on the blood vessels that fall along the tracheal wall, and it can actually cause damage to the tracheal wall if we overinflate it for over an extended period of time. So general cuff pressure should be below 25 centimeters of water, and avoid suctioning longer than 10 seconds due to the oxygen loss. And a lot of times with tracheotomies we're dealing with blockages that can be prevented by suctioning with saline and humidified oxygen. But if a tracheostomy tube becomes displaced, don't forget the access of the upper airway. Bag ventilate the patient and prepare for intubation if the tracheostomy tube cannot be replaced, and try to attempt recannulation. So it's facilitated by placing the tube over the dilator or the obturator and re-entering the trachea under direct visualization. But do not forget about intubation while laboring over an increasingly traumatized tracheotomy site. You know, remember, we can still intubate those patients. In the majority of cases, they're still intubatable. So don't forget, you do have that ability. We don't want to sit there and focus all our time and effort on the tracheostomy and let that patient become hypoxic. So this completes the respiratory module. If you have any questions, please feel free to give me a shout. Otherwise, we'll see you soon.